I'd like to welcome tonight's guest, Dr. Matthew Gottman. Dr. Gottman is a local grown product from Rockland County. He was a Clarkstown North Ram. Did I get it right finally?
Yes, finally, after the
Right.
fifth time,
Third
yes.
time. Third time. Wait, see if I get your education right. You went to Penn State where you played free safety, right? 4 year starter at free safety under Joe Paterno, and then went to med school at NYU, and then went to residency at where'd you do your residency? Lennoxville Hospital?
So you forgot that I got drafted to the NFL, right?
Well, you got cut right away.
Got
So
cut. So I went to Stony Brook for medical school,
Stony Brook. All right.
and then
That was
I did my orthopedic residency training at NYU, and then I did a year of,
the greatest fellowship of all time.
and then I did the greatest fellowship at all time at Lenox Hill.
That there you go. Where you did some prolific research projects and helped us with a lot of stuff.
Yes, it was
Um,
great working with NISMET and all the research folks.
yeah, good stuff. The reason I brought you in tonight is because, in fact, you cover a lot of football games. Did you win a state championship in high school football this year? Was that your team?
No, so
No,
Somers won my division, I
they
think.
won your division. Okay,
Yeah, our team, we lost in the first round of the playoffs.
you were Woodlands, right?
We were Westlake.
Westlake. Westlake.
Yeah,
Okay. Did you have any ankle sprains when you were covering Westlake?
of course, of
Yeah.
course.
Ankle sprains come in all varieties, though. They come in inversion ankle sprains, eversion ankle sprains. The sprains we're talking about tonight is high ankle sprains or syndesmotic sprains.
Yeah, yeah. Far and away, the low ankle sprains, the inversion injuries are way more common than the high ankle sprains or the eversion injuries. But in football, they are fairly common. Probably, one of the higher incidents of high ankle sprains do occur in football. So we do see quite a few of them at the high school level as well.
I got a lot of high ankle sprains in linemen by getting their ankles falling on them from other players.
Yeah, that's one of the more common mechanisms of injury, for high ankle sprains, linemen, not, not paying attention to what's behind him. Player falls directly on his leg and then it gets caught underneath him. And
Yeah.
then they go into, eversion, dorsiflexion, and that's the most common mechanism for these high ankle sprains.
hmm And when and when you're seeing those players, whether it be on the field or in the clinic the next day, how do you make the diagnosis of teasing out, a low ankle sprain from a high ankle sprain and seeing if it's a high ankle sprain?
So in the perfect world, they remember their mechanism, right?
Sure.
However, more frequently, people, don't remember which way their ankle went. But one of the telltale signs is the which way their ankle twisted. So, the first thing I do ask an athlete when they come in is, do you remember the injury? Did your ankle invert? And I, demonstrate it to them. Did it evert? Did someone fall on you? How did this happen? I think the mechanism, if they do remember it, is very important and kind of clues you in to what the possible diagnosis would be. Regardless if they remember their mechanism or not, you still have to do a thorough physical exam, which kind of clues you in to, high versus low ankle sprain. Um, you know, High ankle sprains and low ankle sprains both present with swelling, right? So sometimes the location of swelling can kind of clue you in, whereas low ankle sprains, typically have most of their swelling and ecchymosis over the lateral aspect of the ankle, in the area of the ATFL. High ankle sprains can also have, swelling in an area, but sometimes their swelling is a little more diffuse and a little higher up in their ankle. And then, obviously they come in all different grades, right? You could have um, a low grade high ankle sprain that presents more benign than a high grade low ankle sprain. So it really depends on the location of swelling and then palpation. So we know that these high ankle sprains, one of the more sensitive tests is palpating where these ligaments are. And, the AI TFL is an easy ligament in the office that we palpate. So right between the distal fibula and the tibia,
Mm-hmm.
we palpate that particular ligament. We also palpate, the other ligaments around the ankle just to see if they have tenderness over the medial deltoid. We do check the AITFL as well as the ATFL and CFL. If you are concerned of a high ankle sprain, there are some specialty tests that we do in the office. Um, three that I usually always do when I'm concerned. One is an external rotation stress test, right? So you're basically recreating the mechanism of the injury by dorsiflexing the athlete
Mm-hmm.
patient's foot and then externally rotating it. If that produces,
What what position do you do it in? Some people do it in prone. Others like to do it in seated. What position do you prefer?
I typically do it in the seated position.
Okay.
I like examining my ankles when the patients are sitting and hanging off the edge of the table. It
Okay.
allows me to get a kind of get a circumferential look at the ankle, allows me to do, other types of testing, drawer testing. So, external rotation stress test is one of my go-tos for syndesmotic injuries. The other test is the calf squeeze test. So what you do is you have the athlete with their leg hanging off the table and just squeeze in the middle of their calf. Basically, you're squeezing the fibula and the tibia together. And if that
Okay.
reproduces ankle pain, that may be suggestive also of a high ankle sprain. And the last test, which I started to use more and more frequently, is the taping test. So if I'm concerned about a high ankle sprain, I take some Coban or
Yeah.
medical tape and I tape the bottom of their ankle very tight. If that eliminates their pain with either single leg heel
Like a
rises,
closed basket weave or an open basket weave or a figure eight. Like what kind of tape job you doing? You're talking athletic trainer, So
this is a not fancy circumferential, just wrap it around the ankle. No twists, no turns. Basically at the level of the syndesmosis. And what you're doing is you're creating like an external syndesmosis, kind of squeezing the fibula and the tibia together. And if that eliminates their pain, that may suggest that there may be some instability in that syndesmosis. And then, that kind of clues you into that diagnosis as well.
sorry about that, lost you. And you find that effective? Yes. You like that one?
I do.
I've never used it. It's new to me. Good.
Yeah, so I use it when the diagnosis is equivocal, where they have a sprained ankle, they don't remember their mechanism. You do external rotation stress test, it hurts, and calf squeeze, maybe not, and you're kind of deciding, hey, is this a high or low ankle sprain? And I think that's a good tiebreaker test. So I wouldn't say I use it for everyone, but
Okay.
I have been using it more frequently.
Yeah, I would say that if you have two of those positive and you do the wraparound Dr. Gotland test, and that's positive, you're more than likely got a high ankle sprain in your hands.
Correct. Correct.
I like that a lot. Thanks for that education tonight. I learned a lot already.
Yeah,
Appreciate
no,
that.
it's a documented test. I wish I could take credit for it, but it is out there in the literature, and I
Good.
find it very helpful.
I will send me an email and I'll be looking for that and I can send it out to anybody in the audience who wants a copy of that from wherever I find it. From there, now we're off the field, we're out of the training room, and we're in the clinic the next day. Okay.
Yeah,
What's your process there? First of all, we as athletic trainers and physical therapists, we use Ottawa ankle rules. Okay. Do you use Ottawa ankle rules, or you're in the clinic anyway, so you might as well get an X-ray? And then when do you go to the MRI? Can you take me through that scenario?
yeah. So it's a great question. So I don't use Ottawa ankle rules.
Okay.
I Ottawa ankle rules are oftentimes used in ERs, to potentially eliminate, tests that maybe aren't necessary. I feel like with every ankle injury, it's important to get x-rays, except if there is a special circumstance, if a patient's pregnant. If it's a very young patient you don't want to expose to radiation, you're confident that there's no fractures. But a lot of times you'll be surprised. You think you have a simple sprain and you see an avulsion fracture. The X-rays also give you an idea of any previous injury, right? So if they have
Hmm.
any calcification in their syndesmosis, you know that they may have a previous high ankle sprain. So, in your older athletic population, you could also see some arthritis, bone spurs. So, the ankle X-ray gives you a lot of good information. So I'm always getting an ankle X-ray. I would say in 99% of any ankle injuries, except if it's very minor, and very little swelling, very low suspicion, then maybe I would not get it. So X-rays on everyone, do an evaluation, and the MRIs they kind of fall into two categories for me. One, if I don't know the diagnosis, right? Have someone with an ankle sprain. It looks like a significant injury. Not really sure what's going on. Is there a cartilage lesion? Is this a high ankle sprain, a low ankle sprain? So more for diagnosing purposes. And then the situation where you know that what the structure that's injured, right? You know it's a high ankle sprain. But your exam and imaging is worrisome for an unstable pattern, right? You do a stress test on the X-ray and you're concerned that this may be an unstable syndesmotic injury. Those are the patients I'm getting an MRI on to see which structures of the syndesmosis are disrupted, look at the status of the deltoid ligament, and also look for concomitant injuries, cartilage injuries, etc. So, you know,
Sure.
if I have someone that comes in with a low grade high ankle sprain, right, grade 1, grade 2, that is, not a college or professional athlete, I'm unlikely getting an MRI. The other thing it can do a little bit is give a little prognosis, right? So if you work with any college or professional teams, every athlete, regardless of the degree of injury, they're getting MRIs, right? Because the MRI is a little helpful at maybe predicting how long this is going to take to get better just based on the degree of soft tissue injury instead of guessing just with clinical exam. So, I would say that probably less than 20% of the patients, of the everyday patient that I see in the office with a high ankle sprain, am I getting MRIs for.
Excellent, excellent. Donis, did you send every ankle sprain for an X-ray in your training room, Donis?
Not necessarily. We did
No,
in the
you.
sense that, yeah, we
Yeah.
we tested it to see how severe it was and went from there. If anything, we did a follow up with the team doc just to be sure if it was severe enough.
Yeah, I can't say that I sent everybody for an X-ray. I mean, I did use auto ankle rules a lot. I mean, if they couldn't weight bear and they had pain sort of on the malleoli, both malleoli, then I sent them immediately for an X-ray. But the grade ones, I rehabbed out for a week or two before I sent them down the road and saw how they did. Are we doing our athletes a disservice, Dr. Godwin, do you think, by doing that? What is your process on that?
So if you're confident the patient has a grade 1 sprain,
Yeah.
mild pain, minimal swelling, is ambulatory, has no
Mm-hmm.
bony tenderness, I do not think you're doing a disservice.
Okay.
When you're dealing with low ankle sprains, low grade low ankle sprains, you probably you don't need them. They're not that important in the diagnosis. They're just important for ruling out things that may be um, you know that may be unexpected. When you have a high ankle sprain, I think you may be doing your patient a disservice because an X-ray could tell you a lot of information about the stability of the syndesmosis. And the way we treat these really depends on the stability of the syndesmosis. On an X-ray, you can get an idea of medial clear space widening, the space
Yes.
between the tibia and the fibula. And if you have a high suspicion and there's no, gross abnormality on a static X-ray, then you should do a stress X-ray. So I think when you're talking about high ankle sprains, those are patients I would be more inclined to do an X-ray for. The low ankle sprains, the ones that you're confident that are, you know, ATFL, low grade, ambulatory. No, I do not think you're doing a disservice to those athletes.
Excellent clarity. Excellent. But the high ankles, I will send every high ankle sprain for an X-ray to look at how much displacement there is in the. Can you Can you teach us a little bit about a stress X-ray? Like is that just a weight bearing X-ray? Is it where you have lead gloves and you're pressing up, forcing dorsiflexion? Like what's a stress X-ray? And then what are you measuring or looking for to see if you need to do a screw, a tightrope procedure, or treat them non-up? Let's go through that case scenario now.
So that's a good question. So, there's two, so you always get static x-rays and then you compare it to the stress x-ray. And there's two ways to stress the ankle. One's called an external rotation stress test. What you refer to as kind of getting on the leg gloves and reproducing that external rotation stress exam.
Okay.
So, you glove up, you gown up, you're with the patient in the x-ray suite, and you're actually externally rotating their ankle. And what you're looking at is you're looking at two things. You're looking at the relationship between the tibia and the fibula, okay? And then you're looking at the medial clear space between the medial malleolus and the talus. If there's any shifting where widening of the medial clear space or any gapping between the tibia and the fibula, that may be suggestive of an unstable syndesmotic injury. The other way you could do it is called a gravity stress test, where you're not really touching the patient's ankle, but you're letting it hang off the bed. So typically they're on their side and their foot is just kind of hanging off the bed, and gravity is externally rotating their foot.
Ah,
So those are the two ways you do the stress test, and those relationships between the tibia and the fibula and the medial clear space, those are the things you're measuring. And sometimes it's grossly obvious, right, where they're wide apart. You don't have to get out the ruler to make measurements. Is this 3 millimeters? Is this 4 millimeters? It's grossly obvious. Sometimes it's subtle, and you have to, get out the ruler on the X-ray system and really measure it. And if it's, equivocal, then you get contralateral films, get the other side and measure it, because there is some physiologic widening of these joints that happen during these stress exams. So if you have a stress exam that's equivocal, right, where I'm not sure if it's wide, then get an MRI. That's another reason I would get an MRI.
okay. And now you have a positive MRI. You have an unstable syndesmotic joint. Have you put screws in? Have you put tight ropes? I know that the literature says by Twaddle and Marove that people do okay non-op, but it takes a very long time.
Yeah. So I think, that the controversy in this topic is two things. Well, it's very clear that the low grade high ankle sprains don't need surgery. It's very clear that the grade threes or the type threes, that the high grade unstable injuries need an operation. The grade twos, right, are typically treated non-surgically, and they do fairly well, but it takes a long time. Sometimes, if you look at the NFL data, high ankle sprains, the average return to play is 11 weeks. Okay, so in the NFL, people who are getting 7 days a week of physical therapy and rehab,
Yep.
it's taking them 2 to 3 months to get back, right? So these are injuries that take a while. So in that patient population, can we do something to speed up their rehab? Then in the grade threes that we know those are the ones that are getting surgery, can we do a surgery that gets them on the field quicker, right? So
Yep.
there's been a lot of push, not just in this topic, but in a lot of topics for us to use our innovation and implants to maybe give a more anatomic and stable repair to allow these patients to kind of stress the ligament and the joint more. So, the data on the screws and the tightrope, it's evolving, and the screws have been around for a long time, and I've used them frequently in the setting of ankle fractures when I'm trying to stabilize syndesmosis. But I will tell you, I haven't put a screw in a syndesmosis since I've been in practice. I just use tight ropes. So
Okay.
there may be some scenarios, but probably not in an athletic patient, but in someone who may be non-compliant or other medical issues where I need really, really stable fixation, I would put a screw in.
Have you had to take screws out?
Yeah, so yes, some people will take them out before they break, but they almost always break, right? So whenever you put syndesmotic screws in,
Right.
you know, the more common outcome of the hardware is breakage, right? You know, eventually you're going to stress out the screw because this joint inherently has motion, right? Your syndesmosis is not a joint that doesn't move. So
Right.
eventually the hardware is going to fail. So, you know, these almost always break. And when they break, we typically leave them in, okay? Because, you know, there's been a lot of studies that show with hardware removal, you know, sometimes people could do well if you just leave it in as long as it's not backing out or causing any issues. So if they break, it's okay, but we just leave it in. But sometimes if they become prominent or symptomatic, it's an issue because then you have a broken screw that's in the middle of the tibia and it's not fun getting out. The benefit of the tightrope is that you don't have, you know, hardware, you know, breaking, right? You know, the suture could break, but it's, you know, that's not going to cause any irritation. But you know, you have other downsides to tightrope fixation, which it used to be that we used to have to tie knots, right, on the tightrope. Now we have knotless devices, so it's less irritating underneath the skin.
Hmm.
But you know, you sent me a study looking at, you know, screw versus tightrope, and you know, they still had a
Yep.
patient that had to have their tightrope removed because they had some
Correct.
irritation on the inside of the ankle. So,
I've had a patient, an early tightrope patient, when it was first being developed, where the surgeon over tightened the tightrope, and the woman didn't get dorsiflexion at all.
yeah,
She only got to -10 degrees of dorsiflexion because the tightrope was too tight.
yeah. So, you
So
know, from a surgical standpoint, the way we put these tight ropes in is important. The the talus, okay, which is in the ankle mortise, is wider anteriorly than posteriorly.
yeah.
If you put the tightrope in with the ankle plantar flexed, okay, then and you tighten that syndesmosis, you'll never be able to dorsiflex your foot
Right.
because you're locking the syndesmosis in and you can't get a bigger structure through. So when you put these in, it's very important to put them in slight dorsiflexion where the talus is really keeping that, you know, the syndesmosis in position and, you know, anatomically
Right.
aligned. And you know, if you look at all the outcome studies looking at screw fixation versus tightrope, the only thing that really matters is the reduction of your syndesmosis, right? Where
Hmm.
a mal-reduced syndesmosis, regardless if you have a screw in there or a tightrope, the patient's going to do poor. The benefit,
Right.
the benefit of a tightrope is that there's more wiggle room. If you put a screw in a syndesmosis and you're a little off, that thing's not moving, right? The
Okay.
the tightrope, there's some micro motion. So the thought is that you could, you know, put the tightrope in and the chances of you mal-reducing it are less, which is good news. Then an added benefit of it is that because it causes some micromotion or allows some micromotion, you're more anatomically restoring that joint, right? Because that joint moves with ankle range of motion. We know with dorsiflexion, it, you know, externally rotates, it moves a little proximal. With plantar flexion, it internally rotates, moves a little distal. So there's some motion in the syndesmosis. So you're basically restoring normal anatomy with the tightrope.
Excellent. And the reason I chose this article was because it was an early article when they were developing the tightrope, but it compared complication rates and return to play in patients with acute syndesmotic ruptures treated with the tightrope. It looked at a group of patients, 110 in total, which they whittled down to 62, and eventually they got 26 in the tightrope group and 28 in the syndesmotic group. Okay, and what I liked about this study was that the um, the study had some good outcome scores.
Yeah.
Okay, and they followed at 7 weeks. They did outcome scores in 7 weeks, 6 months, and a year out. Okay, there was a couple scores I didn't know. I had to look up. Do you know how to say that? The Molander score. That's a 9 question outcome score looking at different aspects of ankle function. And then the foot and ankle disability index and the AOFAS score, was also used, but they were good outcome scores. And
Yeah, it was definitely very thorough.
yeah, good,
You
well
know,
designed study.
well-designed study, randomized controlled trial. This study is very good, but it's not generalizable to your high ankle sprains because they did have about 50% of their patients with fractures in this study.
Yes,
So, but we know with fractures, there's a high rate of syndesmotic injury. So, and they didn't do like a subgroup analysis to see which one of the purely ligament injuries were,
right.
had different outcomes. But overall, I agree it was a good study.
They returned the athletes to sport in the tightrope group 5 weeks quicker. So if you're looking to get and now if you're looking to get your elite athlete that's playing college ball or quarterback in a bowl game back earlier than 8 weeks. The quickest I ever got someone back is 8 weeks. 8 weeks high ankle sprain.
Yeah,
It's a long time. So
post-op or non-op.
non-op, non-op,
Non-op. Yeah.
non-op.
So yeah, I mean, if historically in the dinosaur ages, when you were a young lad, uh,
When Marvin Jones was the middle linebacker and I was taking care of him with the high ankle sprain. Yeah, it took
right,
8 weeks.
yeah, these were treated in
I
casts,
know.
and if you look at their return to sport for surgically fixed syndesmosis injuries, right? If you look at the timeline of people getting people back, it's between 3 and 6 months in the literature, right? So
That's a big window.
it's a big window. It just goes to show you that there's probably a lot of people that haven't changed their techniques or haven't changed their postoperative protocols, but there's a lot of good surgeons out there that have been doing very good studies, right, supporting their more aggressive rehab protocols with data, showing that we can get these athletes back quicker, right? Obviously, Tua is like, the prime example that kind of caught a lot of media attention. So, some people are getting their athletes back very fast. But I think there's probably a middle ground where we could definitely improve our return to play rate. But I think there's no standardized protocol.
No,
I think if you look at it from a biologic standpoint, right? These ligaments take 6 to 8 weeks to, get some good healing. So if you're getting an athlete back in 4 weeks, right, you're relying on whatever device you put in there because the ligament's not healed.
correct.
So, but I do,
You better make damn sure that all those muscles are functioning perfectly because the only thing that's holding that leg together is fiber wire. So
correct.
and all those things, all those abductors, hip flexors, adductors, quads, hamstrings, gastrocs, soleus, inverters, everters, they all atrophy. Okay,
Yeah. And,
so
and I was pretty impressed with the study that you sent me that showed that the syndesmotic group got back in 14 weeks. Because if you noticed, their post-op protocol had them in a cast for 7 weeks.
yes,
Now, if you tell me that, or told me that I can cast someone for 7 weeks and expect them to get back to sports 7 weeks later, I'd say that's a long shot. All that atrophy from 2 months of casting, that's kind of impressive that they were even able to get their patients back at 14 weeks, which means if they casted them for 1 week or 2 weeks and then started the protocol, they'd probably be able to, kind of meet somewhere in the middle between these really accelerated programs, meaning 4 to 6 week return, versus them, which is, 3 to 4 months. So I think with post-op protocols, even with ACLs, right? There's no absolute standardized protocol. We all have our data and all the data says different things. And it's our job as athletic trainers, physical therapists, and doctors to try to take everything we know and build the best, personalized protocol. I think for, what these studies are showing is that maybe we could push the limits a little bit and get these patients back earlier. But, every patient's different. every patient's anatomy is different, every patient's injury is different, and every patient's expectations and and grit for rehab is different. And the other thing is
Absolutely.
a lot of these accelerated rehab programs, if you look at them, they have their cast off in 3 days. They're doing, it seems like they need to go to physical therapy, 3 to 4 days a week, right? Or at least have access to, the doctor's office very frequently. So, some of these things may not be applicable to, your normal weekend warrior. But for your athlete, your college athlete, your professional athlete, I do think, some of these accelerated rehab programs are definitely doable.
Absolutely, I totally agree. In terms of your, can you just highlight maybe your non-op protocol or post-op protocol? Just so you're full weight bearing right away, you're not. Do you put people on crutches immediately? And how quickly do you get them off crutches with the non-op versus the screw versus the tightrope?
Yeah. So for non-op, we'll just talk about, I guess, the grade twos, like, the ones that are not just little tweaks, right?
Right.
So,
Yes.
yeah, the grade two high ankle sprains, typically put them in a cam boot and give them crutches.
Okay.
I have them weight bear with the crutches, basically as tolerated. And I tell them to wean off the crutches based on your pain. And I have them in the cam boot until they're pain-free walking in the cam boot.
Okay.
Sometimes that's a week, sometimes that's 2 weeks, sometimes that's longer. It really depends on the degree of injury. But immediately they're starting physical therapy, right? So they're not keeping weight off of it completely.
And you're fine having them work quad abductors, adductors, hip flexors, glutes, all that.
Correct.
Okay, good.
So, all up the chain muscle groups, absolutely. Swelling reduction, gentle range of motion, immediately. I think, there's no point to really limit weight bearing except for pain, because the reason
Right.
you're treating them non-surgically is because they have a stable injury. By
Okay.
definition, if they have a stable injury, they should be able to, withhold their weight. If it's unstable, then you should fix it,
You
right?
got to fix it.
Right.
Great.
So for these non-surgical ones, I have them in the boot, basically in the boot until they're pain-free. Then I transition them to an ankle brace, into a sneaker just for some extra support. And again, return to play. There's a difference between return to full competition, getting them on the field. It's somewhere I know this is a very wide range, somewhere in the 4 week to 12 week mark, right? These grade twos that progress very fast. They're in the can boot for about a week. You could sometimes get them back to play in like 3 to 4 weeks. More realistically, high ankle sprain, you're looking 2 to 3 months before you're getting the athlete back on the field.
Now, you're the team physician. I know that I deal with high school athletes mostly, and you've been on the high school sidelines all season this season. But there's a lot of pressure for the coach and the parents that want to get back in the game. Um, do you what makes or break them? Is it the ability to do jumping jacks? Is it a shuttle test? Is it a sprint for alignment? Is it the ability to fire out, get in the stance, fire out? For a female soccer player, is it the ability to dribble, cut, shoot,
Yeah.
defend?
In my experience, it's been more of like explosion power rather than like fatigue related pain.
Okay,
This season I had a uh, high school wide receiver with a high ankle sprain. And, on my athletes, like I said before, for prognosis purposes, I do get MRIs, and he had a low grade high ankle sprain, meaning this is a patient, an athlete that I'm going to progress him as fast as he could, right? Structurally, I know it's stable, and I'm
okay,
going to progress him. So I let him go back to play 3 weeks or 2 or 3 weeks after his injury, and he warmed up. First play, he didn't feel like he could play, right? So he basically self-limited, and he sat out. And then it wasn't until 5 or 6 weeks after he felt confident to go back and play. So it's more of the explosion,
right.
and the cutting and pivoting rather than just like, an achy ankle, so to speak. So, you could tape them, you could put them in braces, but, it's, sometimes it's just that sudden jolt of pain that kind of increases the inflammation. It kind of scares the patient a little bit in the athlete, and
Right.
they self-limit.
When I'm returning someone to play and trying to push the envelope, I'm always thinking about risk reward. So, am I risking further injury for the reward that I'm going to get? And I
Yeah.
do take into consideration what point of the season it is, how many games do they have left? Are they a junior? Are they a freshman? Are they a senior?
Yeah.
Is this a section state championship game or is this a non-league game? But I'm always thinking about risk reward. What is the risk of returning a high ankle sprain too early? Is there a huge risk?
So with any injury, there is a risk of making that particular injury worse, right? So if you have a high ankle sprain that is an isolated AITFL injury, right?
Yep.
PITFL is intact, their deltoid ligaments intact,
Yep.
and that patient has another external rotation stress injury. That force is now being translated right to your PITFL and right to your deltoid ligament, and that becomes an unstable ankle injury that needs an operation. So I completely agree. I had the same exact conversation with my athletes and the parents specifically, right? Where there is a risk of making this worse, where now you have a very treatable injury, non-surgically. You may make this into a surgically treated injury. The other thing is, like, is if the ankle's not strong, right, and you're not confident, then you're putting force through other joints in the body or making yourself more vulnerable, right? So knee injuries, hip injuries. So all these things could happen if you're, playing on a limb that has an injury somewhere else on it, right? So, I think from a risk reward standpoint, correct. If you're have a college athlete that's, getting drafted, or a collegiate or a high school athlete that's in their recruiting year, the risk is worth the reward, right? So for those
Sure.
athletes, you push them, and they take the risk. Everything we do has a risk. I think that, I'm very reluctant, even in a high level athlete, to tell them to really push through the pain, right?
No,
Unless,
I don't do that either.
yeah, there's NFL athletes that miss 8 games because of a hamstring strain, right? So, these are, these are, paid professionals who are at risk for losing contracts, and oftentimes you have to, reference these professional athletes to these lower tier athletes. Wait, listen, this person missed this many weeks. Like, you have to kind of put things in perspective with them.
Hmm. Yeah. Donis, any questions from the audience, Donis, or do you have any questions, sir?
Nothing from the audience, but a question that I had, what's your thought process on like protective equipment and stuff that people could use in the meantime? So like your grade two people or even your people returning to play as a way to kind of protect the repair or protect the injury early on.
Yeah, so if you look at the return to the aggressive rehab, return to play protocols, I think almost all of them have them in a brace at least. So for any of my ankle surgeries, I do have them wear at least like a lace-up ankle brace, or if they have access to an athletic trainer, to have their ankle taped. I think, at least for like the first season back, I think it's just an added protective mechanism. Do I think it's absolutely necessary, right? No pain, no swelling, full range of motion, full strength? Probably not. But I think in the early part of the return to play, I think, taping or wearing a brace. So I almost have all my athletes wear a brace if it's comfortable, when they return, especially post-op.
Okay. I have one off the wall question. Have you ever thought about giving anybody PRP in the synesthesia joint?
So I have never done it before. Um, there's, PRP is interesting, where, it's a very potent anti-inflammatory and it has healing potential. So,
Right.
I think if I had a chronic high ankle sprain that couldn't return because of pain, not instability because of pain, then I think there is a role for PRP.
Okay.
So I've never done it before. I'm not aware of any studies for it, but with PRP, we extrapolate a lot from other joints or a lot of other bodies of research. PRP is oftentimes never dangerous, right? It's your own tissue. It's not manipulated outside, so it's a safe treatment. But I'm not sure of any studies to support it.
Dr. Gottlieb, before you go, can you tell the audience where to find you? Where do you see patients? What do you see? What do you like to see? How do they contact you?
Yeah, so I'm part of New York Orthopedics. I see patients in Manhattan, Westchester County, and Rockland County. So I see pretty much all sports medicine patients: hip, knee, shoulder, ankle, elbow, wrist. So I do all extremities injuries.
You forgot female ice hockey humerus fractures too.
I happen to do a lot of trauma as well. So I do a lot of fracture work. I do a lot of trauma. I do hip, knee, and shoulder replacements, but it's not a large part of my practice. Yeah, I pretty much anyone who has an orthopedic issue that's not a back issue, I'm happy to see them and take care of them. Best way to contact me is probably text or email, or if you have a specific patient that you want to get in the office, I could, Tim, pass along my contact information. I'm happy
Absolutely.
to, call my cell phone, email me. It's absolutely not a problem.
All right. Don, if there's no more questions, I think we'll wrap it up tonight, all right?
Sounds good. Thanks, Doc.
Right. Thanks so much, Dr. Gottlieb. I'll see you soon. All right?
Yeah. Thanks,
all right.
Tim.
Thank you. Bye-bye.
Bye.